Hello students, let's study HIV and hepatitis viruses. So it is HIV AIDS. Morphology, it is spherical and 80 to 110 nanometer in size. It possesses nucleocapsid. So capsid symmetry is icosahedral, 4 nucleic acid. It contains RNA, two identical copies of the single-stranded positive sense linear RNA and viral enzymes like reverse transcriptase, integrase and proteases. The envelope is made up of lipid part from the host cell membrane. Protein part has two components. Glycoprotein 120, GP120 are projected as knob-like spikes on the surface, and glycoprotein 41, GP41 form the transmembrane pellicles. HIV genes and antigens. So there are two types, structural and non-structural genes. So in structural genes, there are three types: GAG gene, Pol gene, and envelope gene, NV gene. So GAG gene codes for core and shell of the virus, precursor protein P55, which is cleaved into three proteins. P24 and P15 constitute the core antigen, and P18 constitute the shell antigen. All gene codes for viral enzymes such as reverse transcriptase, proteases, and integrases, cleaved into proteins P31, P51, and P66. The NV gene codes for enveloped glycoprotein GP160, which is cleaved into two components, GP120 and GP41. So GP120 main receptor of HIV that binds with CD4 molecules on host cell to initiate infection. GP41 is the fusion protein. Non-structural genes regulate viral replication, important in disease pathogenesis in vivo. The transmission of HIV, mode of transmission, viral load is maximum in blood, genital secretion, and CSF. Saliva may contain inhibitory substances like fibronectin and glycoprotein, which prevent transmission of virus. So blood transfusion, risk of transmission is 90%, more than 90%. Parent to child, vertical, 13 to 40%. Injection drug abuse, 0.5 to 1%. Needle stick exposure, 0.3%. Vaginal method, the 0.05 to 0.1%. Anal, the up to 0.5%. Oral, up to 0.1%. Pathogenesis. So first, receptor attachment. Main receptor, HIV enters into target cells by binding its GP120 to CD4 receptor, that is T helper cells on host cell surface. Second step is replication. So it involves fusion, then penetration and uncoating of the virus, reverse transcription, pre-integration complex, integration, and latency. So latency, HIV is different from other latent viruses as it is able to replicate even in latent state and is infectious to the neighboring cells. Pathogenicity classification for HIV disease. So classification system for HIV disease useful for tracking and monitoring the HIV epidemic, for providing clinicians and patients with important information about HIV disease, stage and clinical management. So clinically, so first is acute HIV disease, acute retroviral syndrome. Second, asymptomatic stage, that is clinical latency. Third, persistent generalized lymphadenopathy. Fourth, symptomatic HIV infection, AIDS related complex. Fifth, AIDS, that is advanced end stage. So let's see in detail. So first, acute HIV disease or acute retroviral syndrome following infection. HIV carried to the lymph nodes and other lymphoid tissues where further multiplication occurs in T cells into bloodstream to cause primary viremia. Flu-like illness that occurs in many patients, 50 to 75%, 3 to 6 weeks after the primary infection. There is significant drop in number of circulating CD4 T cells at this stage. Second is asymptomatic stage, clinical latency. Adequate immune response develops within 1 month. Viremia drops down and CD4 cell count becomes normal. State of clinical latency but not microbiological latency. Immune response cannot clear the infection completely. HIV infected cells persist in lymph nodes and there is high level of ongoing viral replication. Third is persistent generalized lymphadenopathy. As a result of HIV replication in lymph nodes, 25 to 30% of infected people develop lymphadenopathy. VGL is defined as enlarged lymph nodes of more than 1 centimeter size in 2 or more sites that persist for at least 3 months. Fourth is symptomatic HIV infection or AIDS-related complex (ARC). After variable period of clinical latency, CD4 T cell level starts falling. Eventually, patient develop constitutional symptoms like unexplained diarrhea for more than 1 month, weight loss more than 10% of body weight, fatigue, malaise, night sweat, mild opportunistic infections such as oral thrush. Fifth, advanced AIDS, characterized by rapid fall in CD4 T cell count, usually less than 200 cells per microliter, high virus load, lymphoid tissue is totally destroyed and replaced by fibrous tissue, opportunistic infection, development of neoplasia, example CNS lymphoma, development of direct HIV-induced manifestations such as HIV encephalopathy. Oral manifestations in AIDS, oral thrush caused by Candida albicans, periodontal disease by non-sporing anaerobes, necrotizing gingivitis, Kaposis sarcoma, herpes 8, oral hairy cell leukemia by Epstein-Barr virus, oral herpes viral infection, dental caries by lactobacillus. WHO clinical staging of HIV or AIDS for adults revised in 2007. So there are four clinical stages. Clinical stage 1 is asymptomatic HIV infection, persistent generalized lymphadenopathy. Clinical stage 2, unexplained moderate weight loss less than 10%, recurrent respiratory tract infection like sinusitis, tonsillitis, otitis media, pharyngitis, herpes zoster, angular cheilitis, recurrent oral ulcers, papular pruritic eruptions, seborrheic dermatitis, fungal nail infection. Clinical stage 3, unexplained severe weight loss more than 10%, chronic diarrhea more than 1 month, persistent fever more than 1 month, and other like oral candidiasis, oral hairy leukopilicia, pulmonary tuberculosis, severe bacterial infection, acute necrotizing ulcerative stomatitis, gingivitis, periodontitis, unexplained anemia. Stage 4, HIV wasting syndrome, slim disease characterized by profound weight loss more than 10%, chronic diarrhea more than 1 month, prolonged unexplained fever more than 1 month. Bacterial opportunistic infection like recurrent severe bacterial infection, extrapulmonary tuberculosis, disseminated non-tubercular mycobacterial infection, recurrent septicemia. Viral opportunistic infection, HSV virus, herpes simplex virus infection, multifocal leukoencephalopathy, say cytomegalovirus infection like retinitis, other organ infection including liver, spleen, lymph node. Fungal opportunistic infection, pneumocystis jirovecii pneumonia, esophageal candidiasis, extrapulmonary cryptococcosis causes meningitis, disseminated mycosis like histoplasmosis and coccidioidomycosis. Parasitic opportunistic infection, toxoplasma encephalitis, chronic intestinal isosporiasis, typical disseminated leishmaniasis, chronic intestinal cryptosporidiasis. Neoplasia, Kaposis sarcoma, invasive cervical cancer, lymphoma, cerebral B cell non-Hodgkin. Other condition, HIV encephalopathy, HIV associated neuropathy, cardiomyopathy. Epidemiology, reservoir, infected people are only reservoir of host. High risk groups commonly acquire infection are homosexuals and people with multiple sex partners and prostitutes, healthcare workers, accidental needle sticks or blood splashes on eyes, intravenous drug addicts, hemophiliacs and other recipients of blood and blood products, people with other STD, sexually transmitted diseases. Laboratory diagnosis, a number of moral, ethical, legal, and psychological issues are associated with positive HIV status. So there are three C's: consent, confidentiality, and counseling. So consent in written format should be taken before the test is done. Patient should be explained about the nature of the test being performed. Confidentiality of a positive test result must. Patient name or word HIV positive should not be written on the report form. Counseling should be provided to motivate the individual to tell the spouse and family and induce behavioral change. Tests for detecting HIV infection. So there are specific tests and non-specific tests. So specific tests are divided into screening test, supplemental test, and confirmatory test. So screening test is antibody detection. So ELISA, it takes 2 to 3 hours. Rapid simple test that takes with less than 30 minutes. Supplemental test, antibody detection, Western blot assay, immunofluorescence assay, radioimmunoprecipitation assay, and line immunoassay. Confirmatory test, P24 antigen detection, viral culture, co-cultivation technique. HIV RNA based confirmatory method, reverse transcriptase PCR, RT-PCR, real-time RT-PCR for estimating viral load. NASBA, nucleic acid sequence based amplification, HIV DNA detection in pediatric HIV. Non-specific immunological methods are low CD4 T cell count, hypergammaglobulinemia, neopterin and beta-2 macroglobulin, altered CD4 CD8 T cell ratio. So first is antibody detection. Detection of anti-HIV antibodies is mainstay of diagnosis of HIV. So screening assays usually take 2 to 3 hours for ELISA and less than 30 minutes for rapid or simple test. High sensitivity, they must detect all positive sera even if some false positive results may occur. Should be confirmed. Results of a screening test should never be used as a final interpretation of HIV status, as the false positive results or technical errors can occur. It is always subjected to confirmatory test. Antigens used in most of screening tests are HIV-1 specific, that is P24, GP120, GP160, GP41, and HIV-2 specific is GP36. So in ELISA, screening test at blood banks and tertiary care sites. Advantage, it is easy to perform, adaptable to large number of samples, sensitive, specific and cost effective. Types of ELISA kits. First generation ELISA uses crude preparation of HIV antigen. It yields more false positive results, now not in use. Second generation ELISA, recombinant antigens of HIV. Third generation ELISA, synthetic oligopeptide antigen of HIV. Fourth generation ELISA detects both HIV antibody and antigen, that is P24, by using combination of recombinant synthetic peptides as well as monoclonal antibodies respectively. Rapid simple tests developed for ease of performance and quick result, require less than 30 minutes to perform and do not require special equipment. Most commonly used tests are dot blot assays, flow through method, immunochromatography, lateral flow assay. Second, supplemental test. So Western blot is the most commonly used supplemental test, available and also recommended by NACO. Then advantage, highly specific antibody detection method and used for validation of positive results of screening test. Disadvantage, expensive, labor intensive, need expertise to interpret. It detects individual antibodies in serum separately against various antigenic fragments of HIV, such as antibody to GAG gene, that is P55, P40, P24, P18. Antibody to Pol gene, example P66, P51, P31. Antibody to NV gene, GP120, GP160, GP41. The antigens antibody complexes appear as distinct band on the nitrocellular strip. WHO criteria, presence of at least two envelope bands out of GP120, 160 and 41 with or without GAG or POL bands. Third, confirmatory test. So first is detection of P24 core antigen. It is detected by fourth generation ELISA. Uses are for confirmation of diagnosis of AIDS, diagnosis of HIV during window period, to diagnose late stage of AIDS, immune collapse or the CNS disease, monitoring the progress of HIV infection, to resolve equivocal Western blot results. Confirmatory test, in that second, viral RNA detection. So detection of viral RNA is the gold standard method for confirmation of HIV diagnosis. Various formats available like reverse transcriptase polymerase chain reaction, RT-PCR, real-time RT-PCR for estimating viral load, and nucleic acid sequence-based amplification. Uses-based method for confirmation of HIV, based tool for diagnosis of HIV during window period, viral load monitoring by real-time RT-PCR. Typing, RT-PCR can successfully differentiate between HIV-1 and HIV-2 infection and can detect the specific genotype or subtype. Detection of drug resistance genes. Third is DNA PCR. So PCR detecting proviral DNA is extremely useful for diagnosis of pediatric HIV window period viral load estimation. In confirmatory test, fourth is isolation of virus from blood or tissue. Isolation is time consuming, expensive, longer time, 6 weeks or more, and not sensitive due to lower number of available cells cultured and paucity of infected cells in the sample that are present. Two methods are being used for virus isolation: indirect method and co-cultivation method. So indirect method, peripheral blood mononuclear cells from patient are cultured in vitro in presence of mitogen phytohemagglutinin. In co-cultivation method, PBMCs from heterologous HIV uninfected donor are stimulated with PHA, phytohemagglutinin, and after 48 to 72 hours, the stimulated cells are cultured along with PBMCs of the patient. Fourth is non-specific immunological tests. So CD4 cell count, measurement of CD4 T cell count is carried out by flow cytometry method. It is useful in assessing risk of opportunistic infection, initiation of antiviral therapy. CD4 count falls below 350, monitoring the response to antiviral therapy. Abnormal proteins like neopterin and beta-2 microglobulin. Summary of lab diagnosis. So for prognosis or monitoring of HIV, CD4 T cell count most commonly used, HIV viral load, P24 antigen detection. Diagnosis of HIV in window period. So window period is initial time interval between exposure and appearance of detectable levels of antibodies in the serum. P24 antigen detection detects by 1 to 2 weeks. HIV RNA detection, PCR based method detects earliest by 12th day. Diagnosis of pediatric HIV, HIV DNA, HIV RNA, P24 antigen, IgG, ELISA only after 18 months of age. NACO strategy for HIV diagnosis. NACO, National AIDS Control Organization, India, has formulated a strategic plan for HIV diagnosis. So there are some points. So first, its first screening test should be highly sensitive, whereas the second and third screening test should have high specificity. The three screening tests should use different principles on different antigens. The same kit should not be used again. Supplemental or confirmatory tests should be used only when the screening result is equivocal or intermediate. So in strategy 1, so for transfusion and transplantation safety, so one test kit is required. So if it is A1 positive, it is positive, and A1 negative is considered negative. Then in strategy 2A, that is for surveillance purpose, two test kits required. So if A1 positive, A1 negative, it is negative. And if A1 positive, you have to use the second kit, that is A2. If A1, A2 positive, report positive. And if A1 positive, A2 negative, report negative. Strategy 2B for diagnosis of individual with AIDS indicator disease with symptoms. So 2 or 3 test kits required. So in that, if A1 negative, report negative. If A1 positive, then second kit, that is A2. So A1, A2 positive, report positive with post-test counseling. If A1 positive, A2 negative, then third kit, that is A3. If A1 positive, A2 negative, and A3 positive, indeterminate. And if A1 positive, A2 negative, A3 negative, report negative. Then in strategy 3, to detect HIV infection in asymptomatic individuals, so 3 test kits required. So A1 negative, report negative. A1 positive, second kit A2. If A1, A2 positive, A3. So here A1, A2, A3 positive, report positive with post-test counseling. If A1 positive, A2 positive, A3 negative, it is indeterminate. And if it test A1 positive, A2 negative, so third kit. So in third kit, A1 positive, A2 negative, A3 positive, indeterminate. If A1 positive, A2, A3 negative, then high risk considered indeterminate and low risk considered. Disinfection. HIV is inactivated completely by treatment with household bleach 10%, infected needle or syringe or 10 minutes for 10 minutes, ethanol 50%, isopropanol 25%, Lysol 0.5% for 10 minutes, hydrogen peroxide 0.3% for 10 minutes, heating serum inactivation at 56 degree for 10 minutes, dried blood or lyophilized blood products would need 68 degrees Celsius for 72 hours, extremes of pH 1.0 and pH 13. Post-exposure prophylaxis is required to reduce the risk of transmission after occupational exposure, such as needle stick sharp injury or mucocutaneous exposure. PEP should be started within 2 hours of exposure if the source is unknown or positive for HIV. Regimen TLE, single daily dose of tenofovir 300 mg, lamivudine 300 mg plus efavirenz 600 mg is given for 28 days. NACO guidelines to prevent neonatal HIV. Pregnant women who are found to be positive HIV reactive are initiated on lifelong ART-TLE regimen. Newborn HIV exposed babies are initiated on 6 weeks of syrup Nivi, Nevirapine immediately after birth. Hello students, let's study hepatitis viruses. Classification of hepatitis viruses. So HAV is the infectious hepatitis virus, family enterovirus 72, that is Picornaviridae. HBV, serum hepatitis virus, Hepatnaviridae. HCV, non-A non-B or post-transfusion hepatitis virus, Flaviviridae. HDV, delta agent, unclassified viroid-like. HEV, non-A non-B, enteric transmitted hepatitis, unclassified calciviridae-like. Hepatitis A virus, infectious hepatitis, transmission fecal-oral route, virus entered through ingestion, multiplies in the intestinal epithelium and reaches liver by hematogenous spread, virus shed in feces during late incubation period and prodromal phase of illness. Clinical features: HAV, most common cause of acute hepatitis of children in India. Two-stage disease, prodromal or pre-ecteric phase, onset, acute or insidious fever, malaise, anorexia, nausea, vomiting, and liver tenderness. Ecteric or jaundice phase, recovery slow, takes 4 to 6 weeks, no carrier, chronic state. Laboratory diagnosis: specimen, feces or serum. Serology: anti-HAV antibody detection, detection of HAV particles, HAV antigen detection. Isolation of virus, non-specific, in test elevated liver enzyme, serum bilirubin levels. Anti-HAV antibody detection, interpretation. Anti-HAV IgM positive indicate acute infection. Anti-HAV IgG detection in absence of IgM, past infection or recovery. Detection of HAV particles, specimen, stool, liver, bile, blood. -2 to +2 weeks of jaundice, immunoelectron microscopy. Hepatitis B virus, HBV, serum hepatitis. Agent is DNA virus, icosahedral symmetry. Pathogenesis: transmission, parenteral route, blood transfusion, needle stick injury, sexual route, vertical. High risk group: serosurgeon, paramedical workers, sex workers, recipients of blood transfusion and organ transplantation, drug addicts. Carrier are grouped into simple carrier, low infectivity, low level of HbA/Ag and no HbE antigen. Super carrier, highly infectious, high level of HbA/Ag, HbE antigen and DNA polymerase, HBV DNA. Clinical features: non-specific prodrome of malaise, fever, headache, myalgia. Complication: fulminant hepatitis 1%, cirrhosis, extrahepatic complications, arthralgia, urticaria, rarely polyarthritis, glomerulonephritis, hepatocellular carcinoma. Hepatitis B vaccine as a immunoprophylaxis. Composition: recombinant HbA/Ag, schedule 3 doses, intramuscular 0-1 6 months. Lab diagnosis: specimen, serum, liver biopsy. Methods: visualization of HBV virus by electron microscopy, immunoelectron microscopy. Serological markers: antigens, HbS/Ag, HbC/Ag, HbE/Ag. Antibodies: anti-HbC IgM and IgG, anti-HbS, anti-HbE antibodies. Molecular markers: HBV DNA. Non-specific markers: elevated liver enzyme, serum bilirubin. Hepatitis C virus, HCV, post-transfusion hepatitis. Mode of transmission: parenteral, exposures to infectious blood. Recipient of contaminated blood transfusion, blood product, organ transplantation, contaminated needles, sharp rings. Injection drug users. Vertical transmission 2%, sexual transmission rare. Does not spread via breast milk, food, casual contact, hugging and kissing. Clinical feature: acute hepatitis 20%, rest asymptomatic in early stage. Chronic disease 75 to 85%. Chronic hepatitis, cirrhosis, SCC, hepatocellular carcinoma. trauma, extrahepatic mix, cryoglobulinemia, glomerulonephritis, arthritis, joint pain. Laboratory diagnosis: HCV antibody detection assay, HCV core antigen assay, molecular methods real-time RT-PCR.
Hope you find this session useful for your understanding and for your exams. Thank you.